Day-to-day problems in pediatric surgery: inguinal hernia, undescended testis, branchial cleft anomalies, pyloric stenosis are the highlights of this edition of Audio Digest Surgery, Volume 17, Number 4, the week of February 25th, 1970. Moderator for this program is Samuel R. Schuster of Harvard Medical School and the Children's Hospital Medical Center in Boston. And it's his voice we hear now.
We have with us a group of men who have had many years of experience in specifically the field of pediatric surgery, and I'm certain can provide some of the answers regarding some of the more mundane problems and the day-to-day problems that you see in the practice of surgery. We're going to do this by having each member of this group have a short presentation of their subject, following which we will have an open discussion period. The first presentation will be on inguinal hernias by Dr. Harry Bishop, who is Associate Professor of Pediatric Surgery and a Senior Surgeon at the Children's Hospital of Philadelphia. Dr. Bishop.
Several months ago, one of the residents rotating from one of the adult hospitals in Philadelphia had me sit down, and the two of us together tried to formulate a table of differences between hernias as we see them in infants and children as compared to adults. I think he was interested in doing this primarily because we're still seeing a fair number of children who are approached as if they were adults, and we, I think, feel this is incorrect. At 3 months of age, the peritoneal comes down, opens the scrotum, and then later, between 3 and 7 months of age, the testicle has formed and comes down adjacent to it and finds its way into the scrotum. Then between 7 and 9 months at the time of birth, the processes obliterates, leaving just a tunica vaginalis, and I'd like you to remember there is a little nubbin of peritoneum up at the internal ring area. It's quite clear that if a premature is born at 7 months, he might well have an inguinal hernia. Sometimes during the closure of this, some normal abdominal fluid gets trapped, and the newborn infant is born with what we call a physiologic hydrocele. This is an extra amount of fluid around one or both testicles, which is insignificant. We do not think it needs to be operated upon, and it will generally go away. Very simply, the obliterative process that takes place with the formation of the various entities that we see. If it's at the 7 months of gestation, it's a complete hernia all the way down into the scrotum. If it narrows, you can collect fluid around in the tunica vaginalis as a communicating hydrocele, but primarily this is an indirect inguinal hernia that we would want to operate on. The other thing we could have is a hydrocele of the cord, and these, in my experience, always have an indirect inguinal hernia above them. The most common one is the short segment of sac, but these are developmental arrests, actually, and this is by far the most common congenital defect that we deal with. If we now try and tabulate the differences as we see them between infants and adults, in the child we're dealing primarily with a congenital problem, whereas in the adult you will have not only the indirect but the direct as well. It is very, very rare that we ever see a direct hernia or a femoral hernia in a child. Once in a while we do, but not very often. The diagnosis is primarily by seeing a bulge and this thing called a silk glove sign, where you're feeling a smooth peritoneal surface running across your finger as you pull the testicle down and run your finger back and forth across the cord. The cord is obviously thickened. This is in contradistinction to the diagnosis in the adult, where you can actually invert the external ring and have the patient cough and feel an impulse. This, if you do it to a child, he'll run away and you probably will never see him again. The interim care, we are opposed to trusts. We do not think there is any place at all for the use of the trust, whereas, as you well know, occasionally in the elderly, poor-risk patient, a trust is in order. The management of incarceration is very different indeed. We feel very strongly that incarcerated hernias in infants and children should be reduced and not operated upon while they're out. And the reason we can do this is that strangulation apparently occurs a good deal later in the infant and child than it does in the adult. You wouldn't dare to push as hard on the adult hernia to reduce it as we do in the infant. Very frequently we will admit the infant to the hospital, we'll put him in a little Trendelenburg, put an ice bag on the hernia, sedate the child perhaps, and then come back a few minutes later and reduce it. We have had no difficulties in using this technique, and it certainly gives us an easier way of repairing the hernia a day or two later when the edema is gone. If you try and do all this at the time it's incarcerated, the sac tears and you end up with a very difficult operation. We are certainly not recommending that we change the approach to the adults in this area, though. Just briefly about the operation. The incisions, we use transverse creases rather than oblique ones. We do not open the external ring. We find we don't need to, and certainly not to have to worry about the tightness of the closure of it is very helpful. The closure of the sac, we are proponents of the twisting of the sac with a high ligation of it. If you open the sac, as you do for an adult, and try and close it with a purse string suture, very frequently it will tear, and you then have great difficulty in closing it, and I think this primarily is the reason for the occasional recurrence that we get. The handling of the sac, because it's so friable and thin, must be done with great ease. Transplantation, I shouldn't use the word never, but we generally feel that since the defect is a residual remnant of a congenital malformation of this area, the whole procedure really should be just the elimination of that extra sac. Therefore, you do not need to reinforce the area. This child is not ruptured in the true sense. All he needs is to have the extra sac removed. And this is really all that's done. As you well know, the transplantation of a cord, or the transplanting of the cord in the adult, is a very helpful thing in order to prevent recurrences. The skin closure was primarily, as in adults, the interrupted skin sutures are still used. The bilaterality, I personally do not feel we should routinely do bilateral hernias. Obviously, it is very frequent, particularly so in prematures and very small babies. If we think there are bilateral hernias, we will operate and fix them at the same procedure. This you might do in adult, but perhaps you'll elect to do them secondarily. But we don't think that you need to stage this in childhood. The time of discharge, all these babies go home the following day unless there's something unusual that's happened to them, whereas the adult stays longer. The aftercare, I mean this now, there are absolutely no restrictions at all. The child is tub bathed, he's allowed to go back to school as soon as his mother wants him to, he rides his bicycle, he climbs trees, there is absolutely no restriction whatsoever. Whereas the adult, as you know, your recurrence rate is higher unless you limit their activity and avoid increased intra-abdominal pressure. The recurrence rate by this technique in our institution is roughly 1 in 300 compared to around 1 in 20 for the adults. So that I think there are reasons for us to continue with this approach of trying to just take care of the embryological remnant and not trying to do a more complicated correction that you would do in an adult patient.
The next presentation will be by Dr. Robert M. Filler of the Children's Hospital Medical Center in Boston. Dr. Filler is Assistant Clinical Professor of Surgery at the Harvard Medical School. Dr. Filler.
The problem of the undescended testis is one which is really quite common in pediatric surgical patients, and although not quite as common as the inguinal hernia, probably occurs somewhere in the neighborhood of 2% of all boys have one undescended testis. Just a brief word of review about an undescended testis in terms of terminology. By the term, we mean a testis which cannot be brought down into the scrotum by usual physical examination. A word synonymous with this is cryptorchidism, which in its original meaning meant an intra-abdominal testis. It has now come in the literature and in common usage to imply the same thing as an undescended testis, that is, a testis which might reside any place between the lower pole of the kidney, where the testis first begins its development, anywhere from that intra-abdominal position down to the upper scrotum. One other term that perhaps needs one word of definition is that of an ectopic testis. In the embryonic development of the gubernaculum does not only send out fibers into the scrotum, but the gubernaculum sends fibers to the perineum, femoral areas, and suprapubic area, so that in the maldevelopment of the testis and the maldescent of the testis can be found in any of these locations, that is the perineum, femoral region, or even in the suprapubic region, and cannot be brought into the scrotum. The word retractile testis is of great interest because a retractile testis implies a testis which is not undescended. And perhaps as many as 80% of children that we see thought to have an undescended testis really have a retractile testis. And it is very important to make the distinction because a retractile testis really requires no treatment but reassurance of the family and the patient. The retraction of the testis is due to a very active cremasteric reflex, which is quite common in young boys, and it has the ability of removing the testis from the scrotum as the cremasteric reflex takes place, and one cannot see it in the scrotum, but one can bring it down into the scrotum with careful examination. Now, sometimes it is helpful to put a boy in a warm tub and carry out an examination under those circumstances. Sometimes squatting will allow the testis to drop down into the scrotum so that one can see it. A history is very useful in this regard because often the mother will say that she occasionally sees a testis in the scrotum, but whenever she manipulates the area, she notices the testis retract. The incidence of undescended testes in 1,400 patients, the right side is more common than the left, but bilateral undescended testes are still quite a common problem. About 24%, and only about 1% of the undescended testes fall in the ectopic position. I might mention at this point in this discussion, I am not talking at all about patients who have problems with sex determination. There's a small number of patients with undescended testes, hypospadias, bifid scrotum, in which there is a problem as to whether the boy is a male or a female, but these patients that I'm referring to, there has been no great problem in making this differentiation, even in the bilateral testes. Important features in the clinical diagnosis are that the normal corrugated skin of the scrotum is absent. The small scrotal sac is a very good indication that a true undescended testis exists in the patient. It's important in the physical examination to try and feel the testis in these areas because the results of surgery and some of the other complications really do depend whether the testis has come out of the internal ring and resides in the canal or in an ectopic position, in contradistinction to one which remains in the peritoneal cavity and intra-abdominal undescended testis. Most of the testes that we see do reside outside of the internal ring. Now, some of the reasons that surgery is performed for this particular condition, fertility, I would say, is probably the number one reason that we try to bring the testis from its undescended position and put it in the scrotum. The current theory, and the one that has been thought of as being the reason that the testis does not function in the undescended position, is because of a temperature differential between the scrotum and the lower abdominal wall or intra-abdominal cavity. Testes which do not descend by puberty or are left undescended after puberty lose the ability to produce sperm, although they still have the endocrine function and will produce testicular hormone. Now, trauma is very much more common in the undescended testis because of its position in relation to a pubic spine or in the ectopic position. There are many psychologic problems that exist in boys with undescended testes as they walk around the locker room, especially worse in bilateral undescended testes. The problem of hernia, in that there is a patent processus with almost every one of the undescended testes, and if nothing else, there's a potential hernia or place for bowel to enter the inguinal canal with almost all of the undescended testes, although only about 30 to 40% of them actually present with inguinal bulge of a bowel protruding in the groin. Torsion of the testis is very much more common in undescended testes, and about 50% of all torsions occur in the undescended testes. A word about neoplasia. The incidence of testicular neoplasms are very much greater, and they usually occur after puberty, about 30 or 40 times as great as the incidence in undescended testes. And there is not really good evidence to prove that if one puts the testis back into the scrotum, this will prevent malignancy, but we feel that the indication in this regard is one that the testis then is in a place where it can be better examined and would be more obvious if a neoplasm did develop. I might say a few words about timing of surgery. Now, the timing of surgery is of great importance and is one of dispute, but there are several factors that add into one's decision as when to perform surgery, and it's based on the fact that at birth, somewhere about 4% of all infants, and it's even higher in preemies, have undescended testes. But if one then goes and examines boys and adults, one finds that the incidence of testicular maldescent is down about 0.3 or 0.4% of all males. And therefore, that sometime during the first year of life, it's very much more common, but certainly even beyond there are a significant number of testicles which do descend on their own. So in this particular situation, one would like to avoid surgery. Well, the hazards of waiting are that changes occur in the testicle when it's left in the undescended position. And the best evidence we now have is that somewhere about 5 years of age, histologic changes can be seen in the testicle that remains undescended, but thereafter they become more progressive, and certainly after puberty the testis loses its ability to make sperm. Therefore, somewhere between 5 and 10 years seems to be a reasonable number. Various people choose different ages, with one exception, and that is the child who develops a hernia at an earlier age, and then I think most of us would feel that we would go ahead and fix the undescended testis and the hernia at the same time to avoid the complications of hernia. The principles of surgery, adequate exposure is important. We like to find the shortest pathway from the undescended testis to the scrotum. There should be minimal tension on the testis, and we feel that a retroperitoneal dissection of the spermatic vessels is important to give adequate length. An incision much used as same incision is used for adult herniorrhaphy incisions. Carried down external oblique, open the undescended testis and its surrounding tunica, dissected free, and the inferior epigastric vessels are divided to give more length in the posterior wall of the canal. This again makes a shorter distance for the testis to be brought into the scrotum. The tunica is divided from the spermatic cord, and this portion of the tunica is sutured. The retroperitoneal dissection then starts. A transfixing suture is placed through the testis, a pocket made in the scrotum, and passing this suture through the scrotum enables us to put tension on that testicle. Closure, and the testis put on traction to the opposite thigh with a rubber band. An alternative method of fixing the testis that we have recently used, which we call a septopexy, the finger dilating the scrotum as before, and the testis will be fixed to the midline raphe between the right and the left scrotum. And this, in the recent series, has given equally good results. What one can expect in this series of patients, there is agenesis of the testis found in about 5% of the undescended testes, and there are dysplastic testes that are seen in about 7%. An atrophic testis has developed later on following surgery in about 1%. Retraction of a testis, which was thought to be in the scrotum, has been found about 1%. About 1% the testis couldn't be brought down in one operation, and the operation was staged. But about 85% have satisfactory results as far as the testis and the scrotum is concerned. So far as fertility is concerned, it's very difficult to know because so many of these are unilateral undescended testes. But in a smaller studies of bilateral testes at our institution, somewhere about 80% of these boys with bilateral undescended testes have been found to be fertile by various means.
The next discussion of bronchial cleft anomalies will be by Dr. W. Hardy Hendren III, who is Clinical Associate in Surgery at the Harvard Medical School and Chairman of the Division of Pediatric Surgery at the Massachusetts General Hospital. Dr. Hendren.
In the next few minutes, I would like to mention some of the more common problems the surgeon sees, which are anomalies resulting from the bronchial cleft system of the very early embryo, and also, perhaps even more important, mention some of the differential diagnostic considerations that come to view for the surgeon. First, a pre-auricular tab, which is a developmental holdover from the first bronchial cleft. These are common. These present no real problem. They should be surgically excised. They often contain a bit of cartilage in them, and their excision presents no particular problem. The one with pre-auricular sinuses, however, you see sinus tracts. One should be very suspicious when approaching these surgically that there may be more there than meets the eye, because in some of these first arch anomalies, this sinus tract winds its way rather deep down in to join the ear canal and circles around the facial nerve. So if one approaches these with the thought of doing a quick operation and suddenly finds that the thing is going deep, one should be prepared to do a formal facial nerve dissection. The way we approach the facial nerve is to use the classic Adson-Ott incision, a Y-shaped incision around the ear, reflecting the ear upward, and then staying close on to the cartilage of the ear canal, following it right down to the stylomastoid foramen, from whence emerges the facial nerve, and we then trace the nerve out as it goes up onto the back of the parotid gland, and once having identified it for certain, then there is no difficulty of inadvertently cutting it and removing one of the first arch bronchial cleft sinuses. A very nice cosmetic result that this operative exposure of the nerve gives. It is not a mutilating procedure. Now, another first arch anomaly that the surgeon is sometimes asked to see is the Pierobas syndrome, or mandibular hypoplasia, in which there is retro displacement of the tongue, and these babies present as respiratory and feeding problems in the neonatal period. And so the surgeon is occasionally called upon to do a tracheotomy, also a feeding tube in place, those two maneuvers, or a feeding gastrostomy. The majority of these babies can be handled conservatively, though. We like to feed them in the erect position with a cleft palate feeder, keeping them upright, and then keeping them on their face in the bed to keep the neck extended, which brings the tongue forward and will often overcome their difficulty breathing. Very innocuous looking thing. It's a little draining sinus tract at the base of the neck. Typically these are anywhere along the anterior border of the sternocleidomastoid in the lower neck, and often there is just a little mucoid discharge. Now, when approaching these, one should be very suspicious that this tract is rather extensive, because most commonly it goes all the way up through the full length of the neck and enters the tonsillar fossa right at the base of the tonsil. The way we approach them surgically, we do not make a long incision throughout the length of the neck, which would be convenient for the surgeon, but it's unnecessary. Instead, we use this stair-step incision approach, a small transverse incision around the mouth of the sinus, carefully freeing it up as far as you can go through that incision, and then making a second incision beneath the ramus of the mandible, pulling the specimen through, and then following it on up into the tonsillar fossa, ligating it and amputating the whole thing. The upper part of this tract characteristically runs right through the carotid artery bifurcation, and so one must take care in doing that upper dissection through that small incision. Another branchial cleft remnant is a midline cervical cleft, the little sinus running downward. I think the main importance is how cosmetically to remove this unsightly thing, and we would do that through a Z incision several days after, excising it and then converting it into Z flaps, which when healed gives a very pleasant cosmetic end result, as compared to a vertical bridle incision in the middle of the neck. Now this branchiogenic cyst, the location of these cysts is typically always along the anterior border of the sternocleidomastoid. And so if one has a cystic mass which is in the posterior cervical triangle, it is probably not a branchial cleft cyst or branchiogenic cyst. The excision of these offers no particular problem. And yet, judging from the cases that are referred to the surgeon with this diagnosis, I think that the diagnosis of this does create quite a problem, because there are a lot of lesions that are not branchiogenic cysts that are sent to the surgeon with that diagnosis. Whenever we see a cystic lesion in the base of the neck, we always get a chest film, because occasionally one of these cystic hygromas extends down in the mediastinum, and the bulk of the thing is actually in the chest rather than in the neck. Something which should not be confused in this case with a branchiogenic cyst. It's just to remind you that tuberculosis is still with us, and the typical scrofula with soft, cystic, cold abscesses in neck. Now, tuberculosis is not always this flagrant. A solitary mass in the anterior neck, which felt cystic, proved at excision to be typical acid-fast infection. Another differential we see occasionally in the small baby with a big mass in his mid-neck bordering on the sternocleidomastoid, and this is in fact his sternocleidomastoid muscle. This is acute torticollis in the small infant, and one does not treat that by excision but by stretching exercises. We should not mention cysts in the neck without including the thyroglossal duct cyst. Just reminds you of their embryology. The thyroid starts its development at the foramen cecum at the base of the tongue, descends through the tongue, through the center of the hyoid to rest at its location in the lower neck. And thyroglossal duct cysts can occur anywhere along this pathway of migration. We should mention that sometimes these thyroglossal duct cysts can be off of the midline. And so whenever removing a cystic mass in either the midline or slightly off of the midline, whether it's in the submental position or lower, one should look carefully for a tract going to the hyoid bone. Because what is necessary to keep them from occurring, one must excise the cyst and the tract and the center of the hyoid bone, and also the tract that extends up into the base of the tongue. And we must remember that cystic masses off of the midline of the lower neck may be the thyroid. The typical case that we see in small infants referred as a branchiogenic cyst are not these cysts, but represent a deep cervical abscess, and they characteristically occur in the posterior triangle of the neck instead of anteriorly.
The next discusser will be Dr. J. Alex Haller, who is the Robert Garrett Professor of Pediatric Surgery at the Johns Hopkins Medical School and Chief of the Division of Pediatric Surgery at the Johns Hopkins Hospital. Dr. Haller.
I would like to consider with you some of the understanding which has developed over the years about pyloric stenosis and touch upon some of the technical aspects which have been helpful in our experience. Hypertrophic pyloric stenosis is a congenital abnormality. We know that this is the case because it has been described in stillborn infants and in prematures and also in newborn infants. Why then do we classically have the symptoms associated with it, namely vomiting, usually projectile in nature, somewhat later in the neonatal period? Probably at birth, the hypertrophied area of the pylorus does not completely occlude the pyloric canal. There is other suggestive evidence that this is the case because there is no reported incidence of having increased amniotic fluid in the pregnancy associated with pyloric stenosis, and we know that most complete obstructions of the GI tract are frequently associated with polyhydramnios. So that in all likelihood this is not completely obstructed, but probably as the child begins to eat and the curds begin to hit against this area of the narrowed pylorus, edema develops, and it is this secondary trauma, in other words, the acquired aspect of this congenital lesion, which is responsible for the symptoms of projectile vomiting. The projectile nature is accentuated by the fact that there has occurred considerable hypertrophy of the gastric musculature. And so this is a very powerful muscle, a very powerful pump, which ejects the contents of the stomach in a projectile fashion. And where there is curds, in other words, where a formula is present in the stomach, complete obstruction may rapidly occur if there is edema at the site of this narrowed canal. On the other hand, if a clear liquid is brought into the stomach, it is often possible to sustain adequate hydration and even to some extent nutrition in babies with pyloric stenosis without going to intravenous feedings. I mention this because I think most of us have become wedded to the concept of beginning such children with suspected pyloric stenosis on intravenous fluids, but it's not entirely necessary. It's the curds or the solid part of the contents of the stomach which cannot get through this narrow canal. Often pure liquid can pass very easily. One of the most useful aspects of diagnosis and management of the child suspected of having pyloric stenosis is the proper method of examination of the child. No small infant will allow himself to be attacked abdominally, and unless the surgeon who is suspicious of pyloric stenosis will take the time to sit down at the side of the baby's bed, have the child relaxed, usually eating, the hand warm, it will be practically impossible to palpate the typical mass in the right upper quadrant. With the child taking glucose water or some other clear liquid, and with the surgeon at the bedside with a warm hand gently palpating in the right upper quadrant, it is usually possible to palpate this telltale mass which is typical of the hypertrophied pylorus. If this is present, this is all, in the terms of preoperative evaluation, necessary for the diagnosis and for operative intervention.
Excuse me, Dr. Haller, momentarily, to say that this doctor concludes this side of your reel. On side B, Dr. Haller continues his discussion of pyloric stenosis. And to hear this, simply reverse your tape recorder's 2 reels or cassette. This is side B, Audio Digest Surgery, Volume 17, Number 4, the continuation of a program on day-to-day problems in pediatric surgery. As we rejoin the panel, Dr. J. Alex Haller, Jr. resumes his discussion of pyloric stenosis.
It is not always possible to palpate this mass. In our experience, if it is palpable, X-ray studies are not in order. On the other hand, if this is not palpable, or if you're not certain of its presence, or if there are other atypical features associated with the vomiting, for example, does the vomitus contain bile? This would be very unusual with pyloric obstruction per se. If there is blood in the vomitus, although this can occur, it is unusual. These would be features which might perhaps indicate a more thorough investigation of the small infant suspected of having pyloric stenosis. And if this study is carried out, quite typically, this narrowed canal will be demonstrated, the so-called string sign, and the tremendously dilated stomach proximal to it. There are some real dangers associated with filling the stomach up with a thick barium medium, the major problem, of course, being that of aspiration. And so this should be a small amount of thin barium or a water-soluble solution of contrast medium to define the area of obstruction. And as I have indicated, this X-ray study is certainly rarely indicated in the evaluation and management of the child with pyloric stenosis. There has been a great deal written about all kinds of replacement solutions and fluids available in the preparation of the child for his operative procedure. Suffice it to say, if this condition is suspected early enough, as it should be, and referred to the thinking doctor soon enough, there should not be a long period of preparation necessary, because these babies will not be that depleted. And they will not then have to float around in a sea of indecision concerning the various types of fluid replacement which may be necessary. To be sure, if this has been a neglected infant and the diagnosis has not been entertained early enough, then there may be significant dehydration, and this may be associated with the typical findings of a loss of chloride and potassium. And both of these electrolytes will have to be added to the hydrational management of the infant. But by and large, the kidneys are available to help in this, and if the saline solution, the dilute saline solution, is given to the child who is severely dehydrated, ordinarily this will be an adequate form of preparation. Unless there are pulmonary complications due to aspiration, these infants should be prepared for their surgical procedure within a few hours after the surgeon sees the child and makes his presumptive diagnosis on the basis of his palpation. The management in the operating room is a critical one because many of these babies still have formula present in the stomach, and this formula, this curds and whey, must be removed before the anesthesia is begun. Otherwise, as relaxation occurs, this may run up into the posterior pharynx and down into the tracheobronchial tree. This is very thick material, and an ordinary small nasogastric tube passed into the stomach may not evacuate completely the thick curds present. This requires a fairly sizable tube and often must be passed orally rather than through the nose. In any event, this is an important preparation prior to induction of anesthesia. The operative procedure is now a very well documented one in terms both of the technical aspects and the good results. The Frede-Ramstedt pyloromyotomy, the narrowed area of the pylorus, the anterior incision being made through the musculature, and the spreading with this herniation of the mucosa, relieving the mechanical problem. There's been much written about various incisions which are best for this procedure. I suspect that the fact that so much has been written about incisions indicates that we have to be concerned with something about this condition since no one understands its exact etiology. And I would suggest that perhaps much of this time could be better spent in trying to understand what the altered physiology and abnormality is at the pyloric itself, because it probably doesn't make a great deal of difference what type of skin incision is made. We prefer a transverse incision personally, but the vertical incision, which has also been popularized, is certainly adequate. The important thing is to be able to see the area of the abnormality. Since this is not associated commonly with other intestinal anomalies, it is not necessary to have a large incision for exploration. And so through this transverse incision, the pyloric mass is delivered. It's been very useful in our hands to support this mass with the index finger over the pyloric end before making the incision for the pyloromyotomy. The pyloromyotomy having been made and the herniation of the mucosa through this incision. A couple of points from the technical standpoint. It is much more important to carry this incision onto the gastric end of the thickened pylorus than it is to sneak down on the duodenum and try to remove every last fiber just before seeing the lumen of the duodenum. The obstruction secondary to pyloromyotomies are much more commonly associated with inadequate extension of this onto the stomach than the failure to remove the last fiber at the distal end of the pylorus. If there does occur perforation at the distal end, this is not a great technical problem. It is a hazard if not recognized, and for that reason, some of the stomach gas should be passed through the pylorus to be sure that there is no leak at that point. A single suture will then close the area of perforation. Occasionally bleeding will occur, but generally this is in an avascular area on the anterior superior part of the pylorus, and so this is not a significant hazard. This is then returned to the abdomen, and the results will be predictably good. In the postoperative management of the child who has had a pyloromyotomy, a couple of features I think are useful, particularly in terms of comparing notes. It is true that these infants may be fed within the first few hours after an uneventful pyloromyotomy. Uneventful in the sense that no perforation has occurred in the duodenum. But some careful studies of vomiting following myotomy from the Children's Hospital in Pittsburgh has suggested that there is a period of atony or absence of peristalsis in the stomach after the operative procedure for 6 to 8 hours, and perhaps 12. For this reason, it is probably worthwhile waiting 24 hours before instituting a formula post-operatively. By and large, the long-term results are excellent with this operative procedure, and interestingly enough, re-exploration later on for other diseases will often reveal a perfectly normal pyloric canal.
Taking up now some questions generated by the four discussions, moderator Samuel R. Schuster turns the panel's attention first to inguinal hernia.
We'll start with Dr. Bishop and ask him if he could tell us why he believes that the recurrence rate in inguinal hernias at the Children's Hospital of Philadelphia is 1 in 300. There have been various reports of recurrence rates up to 1 in 1,000, and there has been some question raised as to whether or not this is related to the fact that the external ring is not opened at the time of operation.
Sam, I think the point I tried to make is that this is a congenital defect, and if you tie off the sac up at the level of its origin, this is really all you should do. I think the recurrence rates come if you tear that sac, or if perchance you don't get high enough and leave a little portion of it. I don't think it has anything to do with whether you open or don't open the external ring, or whether you imbricate, or whether you do a transplantation of the cord to a more superficial position. I think the point that should be made is that this is a high ligation, and you finish, you quit, you go home.
Dr. Bishop, how often do you biopsy the ovary in hernia repair?
I think the question about biopsying an ovary in a female hernia is a very good one, for there certainly is no question that there is an ovotestis possibility. In fact, some pediatric surgeons feel that all these females with hernias should have buccal smears to prove their sex ahead of time. We have not gone that far. Ordinarily, because this is a sliding tube and ovary usually in the small infant girl, we get a chance to look at it. If there was any question about it looking abnormal to us other than having the little cysts that you so often see, we would biopsy it. But we do not routinely biopsy, and we do not routinely do buccal smears. But this is certainly a very good point.
Now, one other controversial point here is about the question of doing routine bilateral herniorrhaphies in infants and young children. And I'd like to poll the panel on that and have them give me their reasons for or against doing routine bilateral herniorrhaphies. Alex, why don't you start?
Well, the data that we need to have is going to be different in every hospital, and therefore it's almost like a religion, and when you have a religion, you can speak about as loudly and as emotionally as you'd like. Basically, the younger the child, the more likely there is to be bilaterality, particularly if there's a large hernia on one side. For that reason, in the child under a year, perhaps under 18 months of age, you're going to have a pretty good batting average if you explore the other side. Now, what do we do personally? We have been exploring the opposite side in all infants under 2 years of age and repairing the hernia or documenting the fact that there's no hernia on the other side. More recently, we have been interested in the possibility of using X-ray studies on these patients, a herniagram, to see if we could document the presence of a hernia sac on the other side. And just take half a minute to mention that this has been primarily a study that we are carrying out to get some better understanding of what does occur in the inguinal canal in children with hernias. This is done by injecting a small amount of contrast medium into the peritoneal cavity, then holding the child upright for about a minute, and then taking an X-ray, and you can document very nicely the whole inguinal area. The real question is whether this has any indications in terms of practical management of a child. It so far is not being used routinely in our hospital, but it has been an interesting study, and perhaps there will be some usefulness for this, particularly in the complicated hernia and where you might not want to explore the other side, for example, with undescended testicles and other abnormalities in that area. But by and large, we have explored the opposite side in all small infants.
Hardy?
So have I, and I think whether one explores it on a slightly older child should be definitely related to how often the person is doing small children, because for the occasional surgeon who does not operate on many children, to explore the asymptomatic side, I think runs some risk of doing harm, rather than just an extra 15 minutes to exclude a hernia sac on the other side.
Yes, we would do the same thing. I might just say one word about statistics. One of the problems when one tries to read if it's bilateral, unilateral, or how many in a series is the difference between a patent processus and a hernia. Now, we have been talking about a patent processus as a hernia, but it's not in truth a hernia, it's just a patent processus. And if one looks through the statistics, one can find many instances where there are a number of patent processes, but very few hernias. Now, the thing that is always of great interest as one sees children is what will happen to a patent processus when the patient becomes an adult. Is this the one that develops his indirect hernia when he's 30 years old or not? I think that's a completely unanswered question. But in regard to what we do, I would just like to mimic Dr. Hendren's words that doing hernias like this every day, we don't have any great problem with it, and we do look at both sides, and certainly the younger children.
As you probably have gathered, I'm adamantly opposed to routine bilateral repair. unless you have indications that there is a hernia on the other side. I think the greatest advantage that the college has ever done is to get rid of unnecessary surgery. And we are now going back to suggesting to people that they always do the other side. Well, this is a terribly dangerous thing to advise. It isn't just a matter of one's experience. It's a heck of a lot harder to explore a side and rule out a hernia than it is to do the side that has a big hernia sac there. And I think we ought to get off this bandwagon and say that we ought to teach ourselves how to diagnose a hernia on the other side. And I think if you put your mind to it, this so-called silk glove sign is a very helpful thing in finding an asymptomatic hernia. Obviously, in small infants, we tend to do bilateral repairs because they're there. Preemies tend to have bilaterals. If you present with one on the left, you're statistically much more apt to have one on the right. So I really think that we ought to be very, very careful in what we say on this subject.
Harry, in this herniogram series now of 100 patients, the referring doctor was wrong 50% of the time when he thought there was or was not a hernia on the side opposite. The house officer who examined the child after he had been referred was wrong exactly the same amount of time, and the staff surgeon who saw the child was also wrong 50% of the time. So that I think if you go on the basis of being able to diagnose the presence or absence, you're going to miss hernias on the opposite side. I would agree with your comment that unnecessary surgery should be avoided, but the teenager who develops a hernia on the side opposite is a much greater problem to him interfering with football, school, etc., than is the infant who can have his repair before beginning his active life.
Well, since I agree with you, Alec, we'll stop it right there. And here's a question for Dr. Filler, and that is fertility. Has infertility been restudied in recent years? Where and by whom?
Most of the fertility studies were done 20 years ago, 30 years ago, in the late 1930s and 1940s, and there haven't been too many really good studies in recent years. However, knowing that the operation really has not changed very much over the course of the last 30 years or so, I would assume that the results might be very similar. Now, it must be said that even these fertility studies that have been done are not perfect. They're not well-controlled studies in many senses. Evidence of fertility has been accepted as having a child in the family, and there has been no other data as to be absolutely sure. There have been some patients that have had sperm counts to be sure about sperm fertility, but there haven't been any really good, totally conclusive studies in this regard.
Dr. Filler, do you biopsy the undescended testis?
Certainly, I would say that more of it should be done. The information that I gave you in regards to at what age does the testis begin to have trouble, most of that was derived from surgical material. More information is still needed in this regard, and most of the biopsies that have been done have been part of a big study in which one is trying to evaluate the effects of therapy. And the routine use of biopsy, unless one sees a mass or is suspicious that there is a neoplasm in that testicle, I think probably is not warranted, except really as part of a larger study. It really doesn't add very much to the patient.
Bob, there are a number of questions here which we couldn't possibly get to with regard to the undescended testis. I'll try to summarize them, and one is, when do you recommend orchiectomy at the time that you do an operation supposedly for an undescended testis? When do you use hormones, and how successful are they?
I think that orchidectomy does occasionally have a place in the treatment of the undescended testis, certainly in an intra-abdominal testis which cannot be brought down, or at least isn't reasonably close to the ring where one might even think that there's any chance of ever getting it into the scrotum, and especially in such a patient in whom the other side is normal. It would seem to me that that would be a good indication to remove that testis, in which the incidence of malignancy is very much higher than even one that's in the canal. Also, one should consider a boy over, say, about 15 years of age in whom the spermatic function is completely destroyed in this testis, with a normal one on the opposite side. Again, this would be another area that one might consider orchidectomy. I might just say one word about what to do about the empty scrotum, and we recently have been using silicone rubber prosthetics, which do very well in terms of the psychological indications and help in that regard. A word about hormones. 15, 20, 30 years ago, people were using hormones widely in various dosages. The hormone used most commonly has been a gonadotropin, and there have been really varying results. And in fact, in most surgical centers, the results of hormone therapy have not been very acceptable, and they were not used, at least among the surgeons. Now, the endocrinologists have on occasion tried them. and the pediatricians. Now, more recently, there's been a recent report from New York that has sort of enlivened interest again about testes that will come down under chorionic gonadotropin injections in short periods of time, a week or 2 weeks as a short course, and they also use a long course lasting about 2 months. We recently have started a controlled study in our patients to see how much good we could do, and it is of interest that there appears to be some of the testes that are what we would call by experienced observers as undescended, not retractile testes, that will come down. And it seems that the bilateral ones, it's more usual for the bilateral ones to descend. Now, again, this is a very small, and perhaps it's even premature talking about our series, of about 30 cases, but it appears that the bilateral ones, it's more successful in those situations as one might conceivably guess, since bilateral ones' etiology might be related to some endocrine dysfunction as contrasted to a unilateral undescent. The group in New York have over 300 testes that they have studied, and again, it looks somewhat promising.
What is the age at which you recommend? You've already given us that. I'd like to poll the panel about when they recommend operation for correction of undescended testicle. Harry, would you make a comment about the age for orchidopexy?
I wish we had time, because there are a lot of things that Dr. Fillery said that I completely disagree with, although initially I started off doing it exactly the way he is. I think if he did it earlier, he would find that he did not have to do this so-called all-American procedure of taking down the back wall and the deep epigastric vessels and going up retroperitoneally. I find that if I do an orchidopexy in a 3 or 4 year old child, it's only maybe 1 out of 15, 20 times that I really have to go to that amount of dissection. I think my results are infinitely better doing them earlier. I think it's nice to get this thing corrected before the child goes to school, and I think there's more and more evidence that harm is done if you wait longer. We will do an orchidopexy any time, but I dislike doing it under 1 year of age, so that I do them between 1 year and 3 or 4. But I think that you have to change your whole concept of operating on this if you're going to do it at that early time.
I agree.
Alex?
We do exactly that. If the child has a symptomatic hernia under a year, we'll also do the testicle pull down at the same time, because obviously you don't want to go back in through scar tissue later on. But I would prefer to have the testicles in the scrotum before the child begins comparing notes, and that usually occurs with attending school. And therefore, there are a number of reasons why it is better, in addition to the anatomical aspects that Dr. Bishop has referred to.
I think there's some danger in some of us making recommendations in terms of doing some of these operations at 1.5 or 2 years of age. Many of us see several of these every week and do a large number during the course of the year simply because we limit ourselves to this age group. On the other hand, if we go out and tell everybody who does the occasional undescended testicle to operate on these babies at 1.5 years of age, I think there is some danger associated with this. So that perhaps caution is indicated here, and there might be some room for compromise in doing them at approximately 5 or 6 years of age when the structures are a little larger.
Sam, could I make one comment in that regard about the hernia repair? I think another reason for not opening the external ring is that we've seen a couple of examples in which the testicle has been handled as in an adult hernia, bringing the testicle up and the cord to get good visualization of this area and dividing the external ring, and then the testicle was not returned to the scrotum in the infant, because sometimes you lose that hole. If the external ring is not divided, therefore the testicle is not brought up into the canal, there is not this danger, and you would not have the problem then of malposition of the testicle, which can cause difficulties. And it certainly seems to me to simplify the operative procedure in the infant to leave the external ring closed for that reason, as well as the others that have been brought out. Open the fascia, the external oblique, visualize the canal, but leave the external ring intact so that the testicle, first of all, doesn't pop up and get in your way, and secondly, so that you don't have it displaced when you try to push it back down into its normal scrotal compartment.
Okay. Here is one for Dr. Hendren, actually several along the same line. With midline cervical masses, especially if thyroid anomalies are suspected, when is a scan indicated? There are several questions with the same contact related to that. Hardy.
I would say that a scan is seldom necessary as a part of the preoperative workup. If we were to find at operation that a thyroglossal duct cyst was the whole thyroid and was in a reasonable position in the neck, we would not remove it, but would split it and lay it off to 2 sides rather than do thyroidectomy.
Does any member of the panel feel that these thyroids should be totally excised if it is an abnormal, isolated midline thyroid and there is no other thyroid tissue? There have been some people who have suggested this, if this is abnormal thyroid anyways.
I would leave the tissue and split it and leave it in the neck, because certainly from the standpoint of functional studies, it seems to be functioning thyroid, and although good thyroid replacement is available, I'd still rather have my own.
I might just say that recently I had a boy that had his only thyroid, which was the thyroglossal duct cyst type, and I split it and laid it on either side, and he came back about 5 years later with really quite a massive enlargement of this, and on biopsy this was thyroiditis, and he was put on suppressive thyroid extract. I think that probably you're right, that these are abnormal thyroids up there. I'm surprised, Hardy, that you're not interested in scanning all these patients when you think a thyroglossal duct cyst might well be its only thyroid. I think it's very nice to know this ahead of time, because if you open it and it's thyroid, if you know there's a normal thyroid below, you'd like to take that whole lump out. Therefore, why not study these preoperatively?
Well, I think it gets down to how common is it. I've seen only one thyroid down in the midline of the neck in 15 years, and in addition to that one that was in the base of the tongue. We categorically decided to remove the one in the base of the tongue because that was causing trouble swallowing. And also the reported cases there suggest that there's an increased incidence of malignancy in the thyroid that's in the tongue. But we haven't made scan a routine part of the workup. It would be elegant to have it, but the yield would be pretty low. Do you routinely scan them, Harry?
We don't routinely do this, but we've, I think, had now 5 or 6, and this is over a 15-year period. So that this is not that uncommon a thing. I don't think you ought to routinely do this if it's an obvious cystic thyroglossal duct cyst, but I think if there's any question about it, I think it's a good idea ahead of time, because otherwise you're just left with great dilemma at the time.
Well, how about let's all palpating the thyroid, and if we can't feel the thyroid itself, then perhaps doing a scan in those patients.
Well, I have difficulty in feeling normal thyroid glands in small children.
One other comment, I think, about the abnormal thyroid, the ectopic thyroid or midline thyroid when no other thyroid tissue is present. Our endocrinologists have almost arrived at the stage when they are willing to recommend excision because they feel that most of these patients have to remain on thyroid treatment anyways because these are abnormal goitrous thyroids in many instances. Here's one for Dr. Haller. Is there any evidence on what residual may persist in adults for those infants with conservative treatment that were not operated upon?
I assume that this refers to the experience in Scandinavia, which has been, I think, perhaps better documented than any series in this country. To my knowledge, there has not been any follow-up GI series type of information on the group of patients who were treated with atropine-like drugs. The interesting thing about that series is that about 10% of the patients who were treated non-operatively ultimately required operative intervention. And I think, therefore, it makes you a little bit leery of any statistics that might come out of it, because there may have been a group of patients with very minor obstructive problems at the duodenum, and indeed these could subside, and I suspect that in that range of abnormality there would be complete resolution. After all, the operative procedure can only take care of the mechanical problem. It should not cause dissolution of the muscle.
Here's a question. I had a case where the stenosis was due to a large Brunner's gland cyst. Have you had any similar experiences? And you might comment on other causes of obstruction in this area that might mimic a pyloric stenosis, Alex.
I have not had a Brunner cyst of my own, but I know that this is one of the entities, a congenital abnormality, which can cause obstruction at the first portion of the duodenum. In terms of the differential diagnosis, of course, there are the congenital stenotic problems, even atresia occurring in the duodenum, the first portion of the duodenum. But since these practically all present with difficulty in the first few hours of life, this is not ordinarily one of the problems in differential diagnosis, since pyloric stenosis usually does not present symptomatically until somewhat later. But it may present in the immediate newborn period. Then there are the diaphragms, mucosal diaphragms present at the junction between the stomach and the duodenum, which can certainly very closely mimic pyloric stenosis. Again, most of these obstructive problems of a congenital basis present in the first few hours or first few days of life. And the unique feature of hypertrophic pyloric stenosis is that it ordinarily does not. And therefore, in the 4 to 6 or 8-week-old baby, there is not a great deal of difficulty in the differential diagnosis at that point.
Thank you, gentlemen. Your next issue of Audio Digest Surgery will be devoted to burn wound treatment, featuring practice-useful discussions of the diagnosis and clinical aspects of septicemia, a review of fluid and electrolyte therapy, topical burn wound treatment, and techniques and adjuncts of skin grafting. The Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association, produces Audio Digest Surgery twice each month, along with 7 other tape-recorded programs of postgraduate medical education. All material in this program is copyrighted, and further tape duplication without permission is prohibited.